But we need to discuss consensus procedures if we will continue to deliver high-quality preventive care in general practice in the different countries in Europe. We need to have consensus. Of course, it is okay with a long discussion before you reach the consensus. But at the end of the day, a patient living in one city should know for sure that he can get the same access to preventive initiatives as the person living in another city, or the person living with one general practice setting should have the same access as the one living with another general practice setting. Let me now turn into symptoms. And here, I will not only challenge us as a specialty, I'll accuse us as a specialty. We are the specialists in handling symptoms, and we do nearly no research in the best way of handling symptoms. In the last few days in the papers in Denmark, they have stated that 300,000 Danes have a worse quality of life than they could have due to different symptoms that the healthcare system are not able to handle. Functional symptoms or somatic symptoms or somatization symptoms or what you call them. But we are the specialists to take care of them. And why don't we have an enormous big research agenda on this? This is an accusation. But I also have the answer why we don't have a big research agenda on that. It's because it is absolutely impossible to get money for that from public funding. All the public funding, they are addressing the red spot here, and they are not addressing what is the real life in general practice. And all of us, we should go out in the society and shout very, very high that the way we fund research in European countries is a failure if you want to develop a strong frontline care, and if by that you want to develop a stronger healthcare system. We should readdress our research funding so that they focus on symptoms, on chronic care, on preventive care, and of course also on biological severe diseases. It is a disaster the way we think research funding in Europe. A little more about symptoms. This is an opinion, this is not research, this is not science, it's my personal opinion. Sorry for that. A little more about symptoms. If you are 50 years old and you wake up in the morning and you don't have pain somewhere, you all know the story, then you are dead. We all wake up in the morning with pain here, pain there, but life has learned us that this pain doesn't really matter. For the same reason, we see in survey after survey that young people more often go to GPs with symptoms than old people, because over life we learn how to interpret symptoms or feelings or perceptions. But someday we begin to think, this perception, might it be a sign of a disease? And we begin to discuss with our family whether we should take access to this healthcare or not. And at some day, we go to the GP and we are very dependent that the GP deliver high-quality work. But as I showed for you before, this limit, the one with the red ring around, is a limit that is pushed according to the way we teach our patients over years to handle symptoms, and according to the way we give signal of accessibility to our patients, and according to the way we interact with our patients. We also should address when should we send these patients to further investigations. Sometimes we should do it, and sometimes we shouldn't. But where is the correct limit for asking the specialists asking the specialists whether there are signs of a disease or not? I like this slide. It's from a PhD thesis from our department from 2003, so it's quite an old slide. But it's an interesting slide in the way that Hans Christian Kelsen, who made this thesis, he made a lot of GPs send all patients with acid acid-related pain in the stomach. The GP should decide this is acid-related pain in the stomach. Please send them to the hospital. And the hospital accepted to do all kinds of investigations, what he could do with those patients with acid-related pain in the stomach. And what came out, and the same type of research is made plenty of times. I see Marianne Rosendahl, who is an expert in somatization, is here. Please ask her for more research projects if you want. But it's made again and again. Even if we think that we know this is a biological disease, more than half of them will turn out not to have a disease we can put a diagnosis on. In other words, as we have been taught on university only to address the red part, the biological disease, when we can't find an explanation, we turn it into a biological phenomenon and prescribe some antacid. And we saw a huge rise in consumption of antacid prescriptions over the last 20 years. Now the curve is beginning to turn back. But the reason that we overused antacid prescriptions to such a degree is that we don't have a proper quality agenda with respect to dealing with symptoms and with respect to dealing with somatization diseases, which are a quarter of the patients sitting in our waiting room. We should seek collaborative care for those patients who have serious unexplained symptoms. A lot of them will have severe disability and lack of ability to work and to cope with society due to all their symptoms. And in some way we should be able to make a stepped approach to patients with complicated, unexplained symptoms. The milder ones we should care. Some of them we should care with, provided that we have been trained well in it. Mariana and her team developed the extended reattribution model for the most complicated in primary care, but some of them should be treated in secondary care. And how do we develop the collaboration with specialists in secondary care in such a way that we can come to what it's all about to avoid that these patients become impaired. And again, if I should address the research funding system and maybe also challenge our research agenda, all of us who are here, I keep asking myself, as we are the healthcare specialists in dealing with symptoms, why in heaven do we continue to develop single disease-oriented research and quality agenda? Look into the chronic care development as we have it just now. We have a tendency to develop a chronic care for COPD and one for diabetes. But reality is that they have diabetes, COPD, and depression, and we should be able to deal with it, all of it. And besides that, they have different symptoms that we don't really know from where they are. So I think we have to improve primary care research on that. And one of the greatest challenges to general practitioners is to deal with symptoms in such a way that we can find the very few with classic severe biomedical diseases and also trivial diseases, but also how to deal with unexplained symptoms, how to avoid the few but severely ill, medically unexplained. In my country, medically unexplained symptoms, stress-related symptoms, and musculoskeletal symptoms are the three main contributors to sick leave and to disability pension. Disability pension in my country, the main contributor are coming from where we are the specialists in dealing with symptoms. And as we are so bad in healthcare to deal with that, we still have far too many people who reach the bottom level of disability due to a lack of early prevention and due to a lack of collaboration with general practice and specialists. This is pessimistic, all of it, isn't it? So let me turn a little more towards future, what is it I want with this presentation? It is to let us reflect on ways forward. And I think that ways forward is to address the issue of accessibility. Do we have a problem with gatekeepers? Or is the real problem that the politicians use gatekeepers as alibi for waiting lists? Do we have a problem that we give a signal of busyness to such a degree that a 50-year-old woman with obvious signs of cancer, this is a concrete case, with obvious signs of cancer, tells my anthropologist, I wouldn't attend my GP because I was so happy with my GP. He was perfect when I had small children. And he was so good to my grandmother when she was about to die. But I've seen again and again, he is so busy, so I wouldn't attend him for my symptoms. And she died from her cancer. Is that the way forward? And when I was president of the European Society years ago, I traveled in all European countries. I traveled to countries where there was list size of 2,600 and to North Italian places where list size was 1,000. But the story I got whenever I left my plane from the GP was, we are so busy. We are hazardous busy. And the politicians don't understand us. And I don't know what to do. In some way, I think we should challenge all that business of busyness talk and begin to address how can we arrange a day where people feel that they have access to us when they need us, and in such a way that our wife can accept us when we come back from work. I'm very happy to see that EQuiP now addresses equity, because there's a huge problem with equity in most countries. In this country, the very big problem with equity is that all of us who are in social top groups, if we need health care, we always know somebody to take care of us. We don't take care of all that gatekeeping stuff and waiting list stuff and all that. We call our good friend and we'll be on track in a day or two.